I am Dr. Saurabh Srivastava, and reader in the Department of Old Medicine and Radiology, BBD College of Dental Sciences, BBD University. And today's topic is occlusal radiography, a part of intraoral radiographic techniques. So to say that we'll be covering this radiographic technique in its introduction, the indications, why is this radiograph needed or where is it indicated, and the various projection techniques, how will it be taken up. So the first thing is that whenever we want to cover a large area of the dental arch which is not visible or which cannot be taken up in IOPF film sizes, we need a bigger size film, which will be the occlusal film. Or if we need an area, any entity which is larger than the film size of intraoral periapical films, then we will need any radiographic technique or a film which is larger than that. So occlusal radiographic film is much larger than the intraoral film. So these radiographs, they are taken at an exposure which is at a steep angulation. So they can be used with conventional periapical films or the radiographs for object localization also. Now the indications, first it is indicated to precisely locate the roots and the supernumerary, the unerupted and the impacted teeth, which are not visible on the periapical film. For instance, is any impacted canine or third molar is present in the bone, which is higher than or at a level in the apical one-third of the adjacent teeth. So it will not be visible totally in our IOPF film. So occlusal film is needed in that case. Then the other indications are to localize foreign bodies in the jaw. If due to any trauma, any foreign body is embedded or any other foreign body is embedded due to accidentally or iatrogenically, it can be localized by using this radiograph along with any other techniques or any other radiograph. Any cyalolith, be it sublingual or submandibular cyalolith, it can also be localized to demonstrate or evaluate the integrity of the anterior, medial, and the lateral outlines of the maxillary sinus. If we are taking the maxillary occlusal view, we can see the sinus outlines, and that can also be seen for its integrity. That means there is no break in the outline of the sinus. Then it can also aid in examination of the patient with trismus. So in patients where intraoral radiography is indicated, but the patient cannot open the mouth. If the patient cannot open the mouth, we cannot put the film inside the mouth, the IOPF film, because the IOPF film has to be placed adjacent to the teeth along the long axis of the teeth. So to place it along the long axis of the teeth, it has to be taken inside the mouth and then rotated in cases of trismus also. But if the mouth is opening very, very little or say only a few millimeters, then in this condition, IOP radiography is not possible other than the occlusal radiography. So we have to take an occlusal film because this film is not rotated inside the mouth, but kept as it is in the horizontal direction only. Then to obtain any information about the location, nature, extent and displacement of fractures of maxilla and mandible. So in cases where fractures are suspected, we can take occlusal radiography. Then to determine the medial or lateral extent of the disease, as we have discussed in introduction part also, that to see the extent of any lesion pathology which is present inside the bone, we have to take a film which is larger than the IOPF film. So an occlusal film will show it very easily, and in most of the cases, any cysts or cases of osteomyelitis or malignant lesions which are present in the bone can be detected with this radiographic technique. Now, what are the techniques which are available? Before going to the technique, we'll say that what is the size of the film? How does it encompass or take the entity which is present in the jaws onto it? How can we film it or radiograph it? Usually the size is 7.7 by 5.8 centimeters. So to say it's 77 by 58 millimeters. So to keep it easy to remember, 77 by 58 millimeters. You can see in earlier books, it was 76 by 57, 1 millimeter less. So this is the latest White and Farrow, which is giving the dimension as 7.7 into 5.8 centimeters. So this film is taken, it is approximately 3 times the film size of IOPA, an adult IOPA film size, type no, size 2 film, which is about 31 by 41 millimeters. Then it is inserted between the occlusal surfaces of the teeth and the occlusal receptors, because the film is called as the receptor of the radiograph. So these are made only of film or storage phosphor plates. Storage phosphor plates will be dealt with you later on in radiography when digital radiography or advanced radiographic techniques will be taken up. So storage phosphor plates, CCD and CMOS, these are the methods of digital radiography where the sensors are used. CCD and CMOS are sensors. Storage phosphor plates are also taking the latent images and it is processed on the computer. So it is a part of digital radiography only. So CCD and CMOS sensors of this much big size do not exist. So occlusal films are, or occlusal receptors are available only in emulsion film or double emulsion film like the IOPA film or the storage phosphoplates, these two only. The tube side of this receptor is positioned towards the jaw to be examined. That means whichever jaw we are examining, the tube side as an IOPA film, it will be having an indent or an elevated dot. That will be the tube side of the receptor. So it will be placed towards the jaw to be examined. Suppose if we are taking the radiograph of the maxilla, we have to place the tube side or the white part of the film towards the maxillary arch or the maxillary occlusal plane. And the X-ray beam will be directed through that jaw to the receptor. That is the basis of taking the occlusal radiograph. And because of the size, its size, the receptor will allow the examination of relatively large portion of the jaws. Okay, this you must be understanding, because it is a larger film, it will allow a larger area to be radiographed. So the standardized projections which are used, they have a desired relationship between the central ray, the receptor, and the region being examined. So what the statement means is that whenever we are taking a standardized projection, we need to see our central ray, which is coming out of the collimator, the receptor, it placed in line with the central ray, and the region being examined, whether the receptor and the central ray are in line with the area of interest. Because if any of the three are not aligned properly, the area of interest may not be radiographed. So various projection techniques which are studied are the maxillary techniques and the mandibular techniques. For the maxillary techniques, anterior maxillary occlusal projection is there, cross-sectional maxillary occlusal, lateral maxillary occlusal is there, then the mandibular techniques are anterior mandibular, cross-sectional mandibular, and the lateral mandibular techniques. Coming to the anterior maxillary or the standard occlusal projection. In this, what we see is the image field, where the primary field with the area which will be covered in this projection, it will include the anterior maxilla and its dentation, the anterior floor of the nasal fossa, and the teeth from canine to canine. So whenever we are observing or viewing a radiograph which is said to be anterior maxillary projection or the standard maxillary projection, it will show us anterior maxilla, the dentition, anterior floor of the nasal fossa, and canine to canine teeth. Means the dentition which will be clearly seen is canine to canine. Other dentition may be overlapping in this case. Then how to place the receptor, how to place the film in the oral cavity. So the patient should be having, should be sitting in the sagittal plane and is perpendicular to perpendicular, and the occlusal plane is horizontal to the floor. So when the patient is sitting, the sagittal plane is perpendicular like this. This is the sagittal plane and it is perpendicular to the floor, and the occlusal plane is parallel to the floor. Okay, horizontal to the floor. So we are making the patient sit in such a position. Then the receptor is placed in the mouth with the exposure side towards the maxilla, if we are taking a maxillary projection as we are talking of it. the posterior border will be touching the ramus of the mandible, because we have to place the occlusal film as far as possible into the oral cavity. And the long dimension of the receptor will be perpendicular to the sagittal plane. Okay? Because whenever we are placing the occlusal film inside the oral cavity, the film will be horizontal or parallel to the occlusal plane and perpendicular to the sagittal plane. The patient will be stabilizing the receptor by gently closing the mouth or gently using the bilateral thumb pressure to hold the film. If the patient is not able to close the mouth properly, or if the patient is biting on the film, because biting also cannot be done on the film, it will create indents on the radiograph. That will be an artifact. Okay, so either the patient lightly or gently closes the mouth, just holding the film in place, stabilizing the film, or can bilaterally apply the pressure from the thumb gently so that the film gets stabilized. Then we have to project the central ray. The orientation of central ray will be through the tip of the nose and will be towards the middle of the receptor, means in the center of the receptor, the patient will be, the central ray will be focusing through the area of interest, and the approximate angle which it will be making, it will be vertical 45 degrees and 0 degrees horizontal angulation, because in IOPA techniques you must be knowing the horizontal and the vertical angulation. And in radiation physics, where the machine was told to you, the IOPA machine, there was an angle meter on the tube head. I had told you the angle meter was used to assess the vertical angulation. There is no meter for horizontal angulation, but for the incisors or in the central, whenever the radiograph is done for the mid sagittal plane or adjacent teeth, horizontal angulation is not given. And the point of entry of the central ray will be approximately through the tip of the nose. Okay, so these things you should be remembering: the angulation, vertical angulation, what is the central ray, where is it projecting, it will be the tip of the nose through which it will be entering, it will be taking up what parts of the teeth, and the maxilla. The pictorial representation will be something like this, where the collimator will be adjusted such that the central ray will be focusing the tip of the nose, and the film will be placed inside the oral cavity parallel to the occlusal plane. This is for the maxillary arch, and such a radiograph will be produced, which will be the anterior maxillary projection or the standard maxillary projection. Then coming to cross-sectional maxillary occlusal projection or the vertex projection or the true occlusal projection. Actually, this is not done nowadays because of certain hazards due to the radiograph or the radiation hazards which are present to the adjacent areas of the maxilla, and also the superimposition of the structures which come in between the area of interest and the this collimator or the central X-ray beam from where it has to be projected, because this will need a 90-degree angulation. So it will show palate, zygomatic processes of the maxilla, anterior-inferior aspect of each antrum, nasolacrimal canals, teeth from second molar to second molar, and the nasal septum. A much larger area will be seen, but superimposition of the bony structures will also be there of the calvarium. The receptor placement will be after seating the patient. The receptor will be placed similar to that taken for the anterior maxillary projection, and the patient will be stabilizing the receptor. Then the central ray will be having a vertical angulation of 65 degrees and a horizontal angulation of 0 degrees to the bridge of the nose just below the nasion towards the middle of the receptor. And the point of entry will be from the patient's face to the bridge of the nose. So it will be at a level which is higher than the anterior maxillary projection. So when it is placed at a higher level, more bony structures will be overlapping the maxillary structures. This will be the diagrammatic representation or the pictorial representation of angulation of the beam. Over here, see the collimator, which is projecting the central beam at the bridge of the nose. You can see in both the ways, in the frontal picture also and sideways also. And this is the diagrammatic representation of the same. Now we can see that this radiograph which is produced, it will show us some part of the maxillary antrum, inferior turbinate in the nose, nasolacrimal canal will be seen, nasal septum is seen, lateral wall of the nasal fossa can also be seen over here, anterior nasal spine can be seen, nasopalatine foramen, lateral wall of the nasal fossa on both the sides. Okay. Then the lateral or oblique maxillary occlusal projection. In this case, the projection will show a quadrant of the alveolar ridge of the maxilla, inferolateral aspect of the antrum, tuberosity, and teeth from the lateral incisor to the contralateral third molar. Okay, and in addition to this, the zygomatic process of maxilla may superimpose over the roots of the molar teeth, as in IOP. So the receptor placement will be similar because the receptor will be the occlusal film which will be placed parallel to the occlusal plane inside the oral cavity, and it will be touching the ramus posteriorly, and it will be positioned the lateral border parallel with the buccal surfaces of the posterior teeth. The border will be parallel to the buccal surfaces of the posterior teeth, extending laterally about 1 centimeter past the buccal cusp. Means somewhat lateral placement of the film inside the oral cavity will be done, and the patient will be asked to stabilize it. Then orientation of the central ray with vertical angulation of 60 degrees in this case, to a point 2 centimeters below the lateral canthus of the eye, and will be directed towards the center of the receptor or the film. So 60 degrees vertical orientation plus 60 degrees and 2 centimeters below the lateral canthus of the eye. So this will be the lateral oblique projection. And the central ray will be entering approximately 2 centimeters below the lateral canthus of the eye. See how. So the pictorial representation and the area which will be covered are seen in this diagrammatic representation and the radiograph. You will be having an oblique or lateral projection on the occlusal film like this. Wherever IOP film projections will not be able to visualize the structures which are deeper into the bone, we have to take radiographs on the occlusal film. So here we can see the floor of the nasal fossa, anterior wall and floor of the antrum, maxillary antrum, and any other structure which is beyond the scope of the IOPFL, that like the retained root of first molar, which is shown in this radiograph, and a picture or superimposition of the zygoma can be seen. Then anterior mandibular or the standard 45 degrees occlusal projection. Coming to mandibular projection techniques, in this projection, the image field or what will be covered, it will the anterior portion of the mandible, dentition from canine to canine, and the inferior cortical border of the mandible. Okay. Now, how to place the receptor in this case? The patient will be seated 45 degrees above the horizontal. That means the patient will be tilted back so that the occlusal plane, it is at 45 degrees above the horizontal. Means to the floor, it is making an angle of 45 degrees. So whenever we are placing the receptor, it will also make an angle of 45 degrees to the floor. So the receptor is placed again like that, and it is pushed posteriorly until it touches the ramen bilaterally. Then the center of the receptor with the pebbled side or the tube side, which will be downwards this time because we are going to take the mandibular radiograph. And the patient will again be asked to bite it lightly or hold the receptor very gently. Whenever the patient is stabilizing with fingers, it is always indicated that the fingers do not come in the path of the central ray. Otherwise, what will happen? The fingers or the bones will also be radiographed. That will come as an artifact. Then the central ray projection, it will be taken as minus 10 degrees vertical angulation through the point of chin towards the middle of the receptor. So this will give a minus 55 degrees angulation to the plane of the receptor, because 45 degrees was the receptor angulation with the flow, and minus 10 degrees you are giving the angulation of the beam. So total minus 55 degrees angulation is given likewise to the plane of the receptor. The entry of the central ray will be in the midline and through the tip of the chin. It will be somewhat like this. You can see the receptor and how the angulation is made. In this, the patient is not tilting the head backwards. So the angulation of the beam or the collimator, it is making a much negative angulation. Means it is more than minus 10. Okay, over here also the central ray will be entering through the chin. So whenever we are making the central ray enter through the chin, it will automatically make an angle of 45 to 55 degrees. Now what all things are seen? See, in this artifactual bite marks can be seen where the patient has pressed it tightly over the film. The upper margin of the lower lip can also be seen as one of the soft tissue shadows. Trabecular pattern of the anterior mandible, lingual pitch or foramen, and the genial tubercles can be seen in anterior mandibular projections. Then the cross-sectional or the true occlusal projection of mandible. This will include soft tissue of the floor of the mouth and will reveal lingual and buccal plates of the mandible from second to second molar. When this view is made to examine the floor of the mouth, like in case of cyaloliths, the exposure time should be reduced to half the time used to create an image of the mandible. So this is very important because whenever we are examining for cyaloliths, they are lesser calcified. So when the radiograph or the time of exposure is similar to that of the mandible or the teeth, the rays or the X-rays will pass through that cyalolith and it may not be visualized as clearly as it will be visualized when we reduce the exposure parameters. So again, the receptor placement. In this case also, the patient will be seated in semi-reclining position with the head tilted back so that the L tragus line is almost perpendicular to the floor. In the previous case, it was 45 degrees, but in this case, it will be almost perpendicular to the floor. And place the receptor in the mouth with the long axis perpendicular to the sagittal plane, just as in the previous case. And the anterior border of the receptor should be approximately 1 centimeter beyond the mandibular central incisors. So in this case, we need the cross-sectional view of the anterior mandible also as well as the posterior. So the film should be covering the anterior mandible also because the mandible is holding the incisors in an inclined position. So the film will be placed 1 centimeter beyond the mandibular central incisors, means out of the mouth 1 centimeter. And the patient will be asked to stabilize the film. Then projecting the central ray, direct the central ray at the midline through the floor of the mouth approximately 3 centimeters below the chin and at right angles to the center of the receptor, because this will be 90 degrees view or the cross-sectional view. We have to position the central ray accordingly. And the point of entry of the central ray will be in the midline and through the floor of the mouth approximately 3 centimeters below the chin. This we can see in the diagrams and the positioning of the patient and the positioning of the collimator and the tube head and the central ray from where does it pass to produce an image of the teeth, which will be seen as cross sections where we can see the canals and the morphology of the teeth. in cross section. Then the various landmarks which can be seen in this are the soft tissue, tongue, body of the mandible can be seen, the mental ridge can be seen, lower lip soft tissue can be seen, mandibular incisors, mental foramen and the genial tubercles are also visualized. Then the lateral mandibular occlusal projection. In this, the image field or whatever area is covered will be the soft tissue of half of the floor of the mouth, buccal and the lingual cortical plates of half of the mandible, and the teeth from lateral incisor to the contralateral third molar. When this view is used to provide an image of the floor of mouth, the exposure time should be reduced as we have seen in the other views also. In this case also, the receptor placement will be similar to the 90 degrees view or the true occlusal view, and it will be placed initially parallel with the sagittal plane and with the pebble side downward towards the mandible, and the receptor is placed as far posteriorly as possible, then shifting the long axis buccally either right or the left so that the lateral border of the receptor is parallel with the buccal surface of the posterior teeth and it extends laterally approximately 1 centimeter. Like in the true occlusal, we used to extend it 1 centimeter beyond the central incisors. In this case, the posterior buccal surfaces of the posterior teeth are kept as a reference. Then projection of the central ray. In this case, it will be directed perpendicular to the center of the receptor through a point beneath the chin. So approximately 3 centimeters posterior to the point and 3 centimeter lateral to the midline, because we are taking a lateral view. Then point of entry of the central ray will be beneath the chin and 3 centimeter posterior and lateral to the midline. This is the diagrammatic representation and the radiograph which will be visualized as the lateral occlusal view. So this will be finishing with the occlusal radiography, and queries will be taken up at my mail ID, and we'll be continuing with the next topic.